Very good evening to everyone, and thanks to the moderator and respected chairpersons. My topic tonight is peri-operative assessment of myocardial deformation. Does it really make a difference? I do not have any disclosures. Now, why talk about a new modality? It's the basic question is about LV ejection fraction. We know that the assessment of LV performance is important because it assesses risk and it helps us guide anesthetic decisions. And LV dysfunction increases the risk of cardiovascular complications and death after surgery. So assessment of LV function is important, but if you use LVEF, it has numerous limitations, including subjective interpretation, geometric assumptions. But I think the most important limitation is more than 50% of heart failure patients would have preserved ejection fraction. So ejection fraction per se cannot be the singular modality for assessment of risk. Moreover, for assessment of RWMA, regional wall motion abnormalities, there will be considerable operative experience requirements, and it is subjective. So a reliable and reproducible quantitative measure of regional and global myocardial function was necessary for a long time. And myocardial deformation analysis is such a newer echocardiographic mode, which is objective, semi-automated, and gives a global and regional assessment of myocardial function. So how can you assess myocardial deformation? There are two predominant techniques. One is tissue Doppler, but the limitation of tissue Doppler, because angle dependent, while using a T probe in the operating room, because the T probe cannot move places like a transthoracic echo, the angle dependent nature of TDI is a limitation for its use in intra-op period. So we are going to focus on spectral tracking echocardiography, which is the angle independent non-Doppler newer technique, and it assesses the LV kinesis in three different axes: longitudinal, circumferential, and radial. Longitudinal is shortening from base to apex. Circumferential is shortening, encircling the short axis of the ventricle. And radial thickening is the thickening in the transverse direction of the myocardium from endocardium to epicardium. So what do you need for assessment of spectral tracking? So what you need is routine good quality 2D images in a mid-cerebral 4-chamber, 2-chamber, and long axis views recorded with clear 2 to 3 cardiac cycles of ECG. And then you should have a newer echo machine with which is having the image processing algorithms like the one in Philips machine that I use, the ACMQ, or automated cardiac motion quantification software, which assesses myocardial footprints or speckles, which is generated by ultrasound myocardial tissue interactions. And the spatiotemporal displacement of these speckles are tracked frame to frame over the cardiac cycle, and it gives assessment of global and segmental myocardial deformation. So in order to perform spectral tracking, what you need to do, the first step would be to identify the region of interest. So in this case, this is a 4-chamber view where the region of interest can be derived by setting 2 points at the 2 ends of the mitral annulus and the one at the apex. And the machine identifies the region of interest by itself. And the operator might have to correct, depending on how the endocardial border is traced, the operator might have to sort of accept it or correct it as necessary. So what it does is it helps assess myocardial strain, which is a unitless measure and is defined as a proportional change in length between 2 time points. And what happens in systole is that LV shortens in longitudinal and circumferential direction. So the strain derived, because the LV shortens, the value is negative, in contrast to radial thickening, because if you look at a short axis view and you assess the radial contraction in the radial direction, there's thickening of the myocardium. So the radial strain that is derived is a positive value. Now, for full assessment of myocardial deformation, both strain and strain rate, because amount of deformation and speed of deformation, both are important. So strain rate is a temporal derivative of strain. For a full assessment, you will need both the amount as well as the rate of deformation. So coming to normal strain values, just to remind you that most of the studies that has been done on strain echocardiography are done on spontaneously breathing healthy subjects using transthoracic echocardiography. And our assessment in the OR using a T is on anesthetized patients whose lungs are mechanically ventilated. So the values would be different. And it is important to note is that when strain is measured with T by using the same analysis software under similar conditions, results are highly reproducible in the operating room. So this is one of our patients in the operating room. And once you set the 3 points, one point which is at the mitral annulus, posterior mitral annulus, another point at the aortic root, or at the aortic annulus, and the third point at the LV apex. In the mid-esophageal long axis view, you can achieve a strain, which is segmental strain. These numbers, which are color-coded, are seen over here. And the global peak strain is given as a number, which is minus 15.9. And similarly, you can have strain value from the 4-chamber as well as the 2-chamber views. And when you combine all this different information, what you can achieve is a bullseye, which is the overview of the function of the entire LV. And you can see the bullseye can show the basal, mid, and apical zones. And you can see the entire picture of it gives you an idea of overall myocardial function in the different zones of the base, mid, and apex. And the most important number over here is the LV global peak strain, which is minus 15.2%, which is slightly less than normal. We'll come to what is a normal range for global longitudinal strain. Now, global longitudinal strain is the most commonly used strain-based measurement of global LV systolic function, and it is the average longitudinal strain of all LV myocardial segments. And this particular paper, the authors write, our experience with radial and circumferential strain analysis is that they are not sufficiently reproducible for routine clinical work. So we would stick to our discussion on GLS only. ASA suggests that the global longitudinal strain of minus 20 is likely normal. So limitations of spectral tracking. So the predominant requirement for spectral tracking is the quality of the 2D image that you save. So the ability to track the spectral pattern and the accuracy of the endocardial border detection is something that you have to keep in mind, because if the quality is not good, both the spectral tracking and border detection will be wrong, and acoustic shadowing and reverberations are to be avoided. Lower frame rates can cause poor tracking, and the operator-dependent functions such as positioning of the region of interest and approval of the final tracking has to be, it depends on you. If you oversee and if it's correct, it's fine. If there's something erroneous, which I'm going to show, like in this image. So this is a software identified region of interest, but you can see it is way away from the endocardial border. So if you accept this, the results will be erroneous. So effective loading conditions, especially because we are talking about assessment of strain in the intraoperative period. So myocardial contractility, we know that changes with contractile state, preload and afterload. So global longitudinal strain would change with increasing afterload. In fact, if the afterload increases, the strain rate and strain rate is reduced. If there's increased preload, there'll be increasing strain, and hypovolemia can reduce strain. And so how does strain make a difference in the perioperative period? So spectral tracking echocardiography-based analysis can differentiate between regional dysfunctions such as coronary artery occlusion and global myocardial dysfunctions such as ischemia, reperfusion injury. Now, this is one of the images where a patient whose baseline was normal, and once the left anterior descending artery is occluded, the entire base, mid, till the apex of the LAD territory, which is anterior and anteroseptal walls, you see they have become pale, and there's hypokinesis over here. So one of our own cases, a patient was undergoing CABG with inferior hypokinesia. Both the EF and GLS improves post-grafting. The GLS improves from minus 10.7 to minus 16.7. And these are the images. You can see it's a fairly good LV. There's inferior wall hypokinesia on the 2D echo. And once you see the bullseye, you can see it was pale before, and there's increased redness indicating that the function has improved. Indeed, if you look at the peak longitudinal strain, it has improved from minus 10.7 to minus 14 over here, which is an improvement. In contrast, this is one of the patients we had, patient undergoing CABG. Post grafting, the EF did not change. There was no detectable RWMA, which appeared on the T examination. But the global longitudinal strain deteriorated from minus 15 to minus 12. So on the 2D echo, you cannot differentiate post grafting. It was almost normal. And if you look at the bullseye and the global longitudinal strain, see, it has gone down from minus 15 to minus 12%. And if you look at the overall color pattern, color coding, it is more pale in the basal and mid anterior anteroseptal walls area. So another case, a 40-year-old man with history of anteroseptal MI undergoing CABG. This man is from Bhutan. And if you look at the bullseye, it was a pale, mostly pale, showing hypokinetic myocardium with the ejection fraction of 33.7% to start with, and had an anteroseptal MI as indicated by the color coding over here. And post-grafting, the GLS improved from minus 10 to minus 12.7. But if you look at the regional function, there are a lot of subtle things, subtle changes that have happened, which is not seen on a 2D echo. Another case with a 72-year-old gentleman with good LV, no RWMA. The initial global longitudinal strain GLS was minus 20, which is normal, except for the fact there was a small area in the mid-inferior wall, which was hypokinetic. And post-grafting, there's a significant improvement, and the global peak longitudinal strain increased to minus 23 in 2 different locations. Fifth case, again a case of anteroseptal wall MI. The patient had no improvement in EF, and the RWMA persisted, but the GLS improved subtle. There was a subtle improvement from minus 8 to minus 11.5 as seen in these images. On the 2D echo, you can see the akinetic or grossly hypokinetic mid-anteroseptal wall. So clinical scenarios where strain might make a difference. So in septic patients with good ejection fraction, with low strain, these are the people, especially the strain, global longitudinal strain is more than minus 13%. It basically predicts in-hospital mortality. So again, another scenario where GLS might make a difference is aortic patients undergoing AVR, patients with aortic stenosis undergoing AVR. And if the longitudinal strain is more than minus 13%, there's increased risk of rehospitalization. And they say that in this particular paper, that every 1% worsening of GLS increases the risk of prolonged hospitalization by 22%. And because LVEF is preserved by left ventricular hypertrophy until late stages of aortic stenosis, LVEF cannot identify patients with subclinical myocardial dysfunction, whereas the global longitudinal strain, if it's more than minus 17% with patients with preserved ejection fraction, it indicates these patients are at high risk. So coming to RV strain, if you want a number for normal global longitudinal strain for the RV, it is minus 29%. The range is between minus 21 to minus 29%. And there are 2 methods of doing it. One is the free wall. The other one is calculating the entire RV, the free wall, apex, as well as a septum. And this is one of the cases that was undergoing CABG in our operation theater. And we assessed the same package, LV package. We assessed the RV and analyzed the RV global longitudinal strain. The value that came was minus 24, which is hypercontractile normal, compared to this patient who had a severe MR with enlarged LA and pulmonary hypertension. And if you look at the global longitudinal strain in this patient, you see the strain is minus 16.3, which is indicative of RV dysfunction. So to summarize quickly, so the take-home message will be specular tracking echocardiography has greater potential for intraoperative use. Strain measure with specular tracking echocardiography is angle independent and can measure 2 axes simultaneously. Myocardial deformation provides important quantitative information on global and regional myocardial function. This is a relatively new technique, and more research will be required to identify the diagnostic accuracy of different strain and strain rate variables and their reproducibility in various disease states. Thank you so much.